Uh, Hello everyone, I'm happy to see you again. And today we have the second class of the webinar. Regarding our topic today will be OPS, ALLIUM stent OPS for spinal cord injuries. Using in this case is TPS, our stent for BPH, but it will be for other indication. And will be performed by Dr. Bonillo from La Fe Hospital in Valencia, Spain. So please, Dr. Bonillo, this is yours.
Okay, thank you very much, Doron. Let's start. I should share my screen.
Yeah, I give you the
host.
I give you the host now. It's yours.
Okay. Let me see. Can you all see the screen now?
Yes.
Okay. Should I start?
Yeah.
Can I start? Okay. Good afternoon, everyone. Thank you for being on the other side of the screen. The topic of today, as Doron was saying, is the use of ALLIUM stent in the neurogenic patient, especially spinal cord injury. First of all, I will I'll wish all of you stay safe from this pandemic disease in this new era. Apologize for the hour in Spain now is almost 3 o'clock. You're tired after all the morning working, but I promise I'll make a very interesting speech, hopefully. I can continue without giving my thank you to ALLIUM, especially to Doron and Julio, to take to account of with us, our hospital, to be the one of showing this prosthesis in this population. As you will know, ALLIUM has a global presence and a regulation worldwide. We are one of the members of this web. We are held in Valencia, in Spain, in the Hospital La Fe. We are a member of the Dr. Professor Rosetta team. And talking about neurogenic bladder, it's been a long way treating those patients. In Spain, we have a long experience with them. We must admit that at the beginning, 5-10 years ago, we didn't like stent because the one we have on the market was the permanent. And we have cases very difficult because of the wire inside the urethra, and we have many complicated cases of infection. But when I review the series in the literature, I must say that the complications we found in this kind of prosthesis are not scarce. We can find over 40% of cases with bladder neck obstruction, merely because of the hyperplastic reaction of the tissue surrounding the prosthesis. We are worried about the fertility of the patient because with the permanent prosthesis, around 20% are not able to ejaculate. And what make me very concerned is about the chance of develop squamous cell carcinoma in almost 5% of the cases. A lesson we have learned from a patient who had permanent catheter in the bladder. With the becoming of the temporary stent, first and second generation, these prostheses, this stent, are more flexible. It's a procedure completely reversible, and have designed some alloy that avoid incrustation, even the tissue ingrowth. Why I think ALLIUM stent is the best solution or the best option is the only or one of the only who have like a 3-year warranty based on their clinical study. They are very simple placement and removal. They are they are self-expandable, and they have like nitinol as a specific alloy with a polymeric coating, make very hard for the stent to develop calcification, stone formation, even tissue ingrowth. Like it happened in those cases where you can see a urethral tissue grow inside the wire. ALLIUM family has like 3 different prostheses, but I only going to talk about TPS, the triangular prostatic urethral stent, not because it has no perfect study or perfect result, but I must admit that TPS studies are all performed on BPH patients. But we admit that the feature of this kind of prosthesis, its rigidity on its cover, confer this prosthesis the best feature to be the one chosen for the neurogenic patient. As I said before, we consider this kind of prosthesis, TPS, is the one we have to choose for this kind of patient. A quadriplegic patient are the model of our sample, who are not suitable for another option, who are not able to perform clear catheterization, or it has complication of his neurogenic bladder, or has not the ability or the possibility to have like a caregiver to make the catheterization for himself. We choose patient who has a urodynamic study that confirmed the true sphincter dyssynergia of the external sphincter, where you can see here in the ultrasound, we see now the bladder neck is closed, but somehow it opened. So that conferred the patient the possibility of use the sphincter just in the external sphincter and leave the bladder neck free. We are aware that there are other options instead of the prosthesis, like the Botox on the sphincterectomy. But you all know that for many years, sphincterectomy has been the golden standard for this patient. But it's an irreversible procedure. Is have an amount of rate of complication like bleeding and structure, and it had damaged the erection and the fertility. It doesn't give any time for adaptation for the patient. But botulinum toxin, apart from the result that you can read in the literature, is not longer its efficacy for longer than 3 months. What make this option depending on the surgeon. What I think is confirmed by another study, the Cochrane collaboration group, where they failed to found any statistical difference between the implantable urethral stent and the sphincterectomy. Even they don't find any difference in any point of using Botox in those patients for a long term. They say that the necessity of reinjection is a significant drawback. Neither the European guidelines on urology have found or make any consideration about using the sphincterectomy before the stent. Neither the international consultation on incontinence have any preference. They say there are different types of stent, that its complications are related more with the material and the surgeon experience, but they said that patient's first choice is a stent, a temporary procedure, instead of a permanent irreversible procedure like the sphincterotomy. However, they insist in making a careful follow-up, even with a cystoscope annually. By the end of the day, when do we offer a temporary stent? The first thing, if the patient doesn't admit an irreversible procedure, or he had to keep his fatherhood wish, or he's very concerned about the erection, we have to think in stent as a third option. Because it's a simple procedure, it's reversible, and it has an proven effective result in a long run. In the population with spinal cord injury, it has to be underlined that the early placement before the 6th month of the trauma gives some benefit to the patient. They don't have to depend on a caregiver for intermittent clean catheterization. Give time for see if he adapts or he can use the condom catheter. He gain time to see if he recover his upper limb mobility that enable him to make catheterization, and give time to him to think about his reproduction issue. However, not every patient with detrusor dyssynergia are fulfilled for this indication. We must select the patient, we must educate the patient, and what I consider the most important thing, we have to handle patient expectation, because somehow is the key of the success of the technique. Patient have to be need to be aware of he will be use a condom because of a permanent incontinence. Maybe he can develop a bladder neck dyssynergia, and he had to be adapt here wheelchair position for voiding, like bending onward, to get a complete emptiness of the bladder. Among the contraindications you can read in this slide, I underline what I consider very important, that patient who has found in the urodynamic study a low contraction of the detrusor are not suitable for this kind of procedure. As you all think, or maybe you are gonna ask me, we don't have like good cost efficient study, but I must say that the cost of the prosthesis is very supplied by the long-term efficacy for almost 3 years, and the less number of reoperation rate. About the surgical technique, I must say that after the patient signed the consent form, we give him the urine culture for before the surgery. 7 days before, he had to take up a urine sample. If it's possible, we have to treat it for 5 days before the surgery. The day of the procedure, we give him a prophylactic antibiotic that we use tobramycin intravenous 240, 3 hours before the procedure. Once we have the cystoscope inside the urethra, we measure the length of the sphincter using the mark coming on the cystoscope. However, you can use a regular ureteral catheter or the radiological measure. Then we have in the ALLIUM set, we have the OPS delivery system that consists in it's like a gun with a trigger button. So it has its safety lock button. In the front position, he have the stent, and on the rear, it has the Teflon sheet. What we have adopted is the lesson we learned from the ecodynamic study. We perform this procedure under ultrasound guidance instead of radiological reference. It gives you the benefit of less radiation, but have the drawback that has to be two surgeons at the same time, as you will see in the video. I must remember that every time you push the trigger, the stent come out about 1.5 centimeter. And once the stent is completely deployed, you have to wait for 5 minutes without any movement. And apart from that, you have to make a slow, slightly semicircular movement and take the OPS delivery system out of the urethra. This is a video we made. As you can see, that's the tools we're using, the OPS, the TPS 06, and I show you what you see on an ultrasound view. That's the bladder, that's the bulb, the bladder, the prostatic urethra, prostate, sphincter, the pubic bone. Now we are able to see both images, endoscopic and the ultrasound images, and you see the jelly coming through the urethra inside the bladder, and you will see now the tip of the delivery tool. We are now on the bladder neck. While we measure, we choose the correct prosthesis. We press the safety button, and without retracting the OPS, we deliver the stent. And a beautiful scene on the screen of the ultrasound. And when you see that the button, the trigger is completely released, that it doesn't have any resistance to press, it means that all the Teflon sheets came out. Wait 5 minutes, and then a slightly movement came out from the urethra. If you have difficulty at this point of the procedure, you wait another 5 minutes and repeat the semicircular movement. As you came out, you'll see how beautiful the stent adjusts to the urethra wall. And in any time, in real time, you can check it on the ultrasound screen. One of the features we love about this prosthesis, TPS, is its anchor, because it fixes the prosthesis, the stent, inside the urethra, and it prevents from migration. You can check anytime the stent position. And what we recommend to the patient is stay at the hospital for 24 hours, especially in this spinal cord injury patient, to observe any complication in the short run. But after 24 hours, we discharge him with the suprapubic tube that we have insert at the beginning of the procedure. And we tell the patient or the caregiver to have the suprapubic tube open in a in a urine bag for the first 3-4 days, and 3 days before coming to the office, use like a tap and close the suprapubic tube in order to observe if any autonomic dysreflexia came out. By the time we want to discharge the patient, we have to prescribe some antibiotic for 5-7 days. We give some anti-inflammatory pills, and we strongly recommend to take L-methionine 3 times a day to make the urine low, to lower the pH of the urine in order to diminish the rate of infection. Another recommendation we can give to the patient is about some voiding position, as I said before, like coming in the front of the chair and bend over his hip to obtain a complete empty of the bladder. We strongly don't recommend any sexual or risky activities. And we ask the patient to come back a week after the procedure to take the suprapubic tube out. Then the month after to see if any clinical issue arise. And then every 6 months, we perform a urine analysis and a transrectal ultrasound to check the correct stent position. If it's necessary, we perform a urethral cystoscope. About complication, the rate is not that high, but in somehow they present any urine infection. Even if the patient develop a more severe infection, we don't recommend to remove the prosthesis at the beginning of the sepsis. But if the patient is not going well, we consider this a possibility. Patient can have hematuria for the first 2-3 days because of the urethral manipulation. What is important to learn the patient about is the presence of any sign of autonomic dysreflexia, like headache, sweating, rise of the blood pressure. That will be an emergency if they have to come to the hospital. And in the long run, we can have some stent migration. As you can see in the picture of the slide, this is the correct position of the TPS, but somehow it has been seen inside the bladder like this. We have developed a technique where you can handle this migration. When the stent migrate a little bit inside the bladder, like a centimeter, we put some catheter jelly inside the urethra, and then we pass through it a 12 frame catheter. We fill the balloon of the catheter, and then we pull back a little bit, not very strong. And anytime you can see on the ultrasound screen how the stent is moving backwards. And you see now that the bladder neck is free, is already closed, and we have moved the prosthesis 1 centimeter. Another.
This is interesting. I want to ask you, when do you do it? I mean, when do you put the jelly and the catheter with the balloon? Right after the procedure, or it can be done also?
No. That's a situation can be anytime in the follow-up. If the patient came to your office and said that he has started to have problem voiding the bladder, he feel like he's sweating, and you make an ultrasound and see that the prosthesis or the stent have moving a little bit inside the bladder, and in this case, just with the catheter inside the stent, put the catheter balloon inside the bladder, fill the balloon inside the bladder, and then pull back. And then the stent very carefully is in the right position.
Nice.
Okay.
It's good tip.
That's our experience. And go on. What I want to say on the long run, at the beginning, our first cases, we found somehow stent calcification, like this picture. It's a mild calcification, because at the beginning we haven't used the L-methionine, and we have seen that after this drug is prescribed, the calcification rate have dropped very significantly. In the very first cases, you'll see it's a very easy procedure to grab the stent with the forceps and the cystoscope, and then if the forceps is not enough, you can pull the wire and it will come out very easily without breaking it. And you see some calcification on the wire. But sometimes that's not that easy, and we found in the very first cases where the patient didn't follow our recommendation, didn't take any antibiotic, or the prosthesis was left for a longer period. Cases like this, like a real severe calcification that make the patient suffer a lot. According to the literature, our result, we see a Spanish long-term follow-up study, where they analyzed 47 patients for over 5 years, and they conclude that different types of the stent, of course, they reduce about 25% the number of urinary. They drop like 1/5 the autonomic dysreflection, but because they use different kind of stent, the rate of migration or calcification is very significantly. They have to remove 1 out of 10 prostheses, 10%. I take this French study because it's one of the few I have found specifically about the dyssynergia. Since is our indication, they conclude that the bulbar urethral stent is not a real alternative for this patient. I completely agree with this group, but I must say that the problem is not the indication, and the problem would have been they have chosen the wrong prosthesis. I completely recommend to use the TPS instead of the BUS stent, because the anchor because of the rigidity of the triangle technology. On the other hand, this other French group, it's a very recent study, said or conclude that after 5 years, they use different kind of prosthesis, different kind of stent. After 5 years, they perform almost 50 cases, and they say that is a completely effective alternative in this kind of patient. So, to conclude, I must admit that the ALLIUM TPS prosthesis has proven benefit in our experience. That is a reversible procedure that gives the patient the time to think about the future, about his fatherhood, about the possibility or not of wearing a condom. And in our experience, is one of the first steps in the treatment of patients with detrusor sphincter dyssynergia that doesn't respond to antimuscarinic therapy. Thank you very much, and I hope you enjoyed the presentation.
Thank you, Dr. Bonillo. Just one comment about the stent you showed with the classification. It was not ALLIUM stent, what you showed in your presentation.
Which one?
You showed the stent with classification.
The one, yeah, no, I wasn't saying it was an ALLIUM. It's not an ALLIUM stent. The one of the video, it is ALLIUM stent.
No,
but
not the video that you pulled the stent out,
yeah,
was TPS.
Yeah. But the one with the hard classification wasn't it?
Yeah. And then you showed the stent with hard classification and the syringe.
Yeah. That's not an ALLIUM.
It's very important to tell the audience that it's not ALLIUM.
Yeah. Sorry about the mistake, but I was trying to show you that it's a complication that is possible, but no, specifically to ALLIUM stent.
It's Taiwan, but I'm not sure.
Okay.
I would ask from you to show again. You show the video of insertion and how you check with the ultrasound. I think this is very important.
The one with the deployment of the prosthesis? Okay. This one?
Yes, and then you see the ultrasound. You see the ultrasound and you see the video through the cystoscope.
Yeah, this is. We found more easily to deploy the stent with the aim of the help of the ultrasound instead of X-ray. The only inconvenience you have to your colleague next to you, especially in the summer, but the image you can get with the ultrasound at real time is very clear.
Also, the tip that you use with
it's at the real in the same moment of the surgery. You see sorry. Sorry, happened. See, you can see now here the bladder neck here. We stop, and you can see at the same time where the tip of your delivery system is. So for us, it's very, very useful.
Yeah, this is very good tip.
Yep. The only thing you need your colleague next to you that hold the ultrasound proof. But once you adapt to be in the same place, it's very easy.
First time I saw you use the tools, it was in your hospital.
Mm-hmm. The procedure is very straightforward. Now it doesn't take longer than 10-15 minutes. You don't have to do any incision or other procedure. This tool is very, very, very easy to use. With the help of the ultrasound, I tell you, it's very, very straightforward.
Yeah.
Very beautiful.
Good image here.
Dr. Miguel, I want to ask a question, please. You discussed about family control or family thinking about, and these kinds of patients with this indication, are they fertile? The ejaculation process is not normal because of the sphincter. So how exactly is that working?
What I want to say is in those patients without any procedure, you are right. The sphincter is being like a trouble for them. If you do a sphincterectomy, no, it's not only that you burn the tissues around it. Maybe you blockage the channel that all the sperm come out. So prosthesis allow to be that tissue intact, and you can use like vibro stimulation, like some tools to make an artificial ejaculation, so you can retrieve some sperm for assisted reproduction. Meanwhile, if you do surgery on the duct of the sperm retrieval, you can blockage then, and you won't have any sample. Only if you have to do testicular biopsy, but I think it's the last step. Okay.
I understand. Thank you.
Welcome.
We have another question from Thomas.
Okay.
There is a question about this question is more about BPH, but maybe you can share with us your experience. If there is a correlation about migration level to the lobes, to the symmetric lobes of the prostate.
We haven't performed any stem for BPH so far, so we're not the right person to answer the question. So I'm sorry to say that that we don't have the experience enough to answer the correlation about migration on the lobes of the prostate. Sorry, Thomas.
I want to introduce Dr. Reinaldo Gomez from Santiago. He's also in our audience today. Gomez?
Yes, good morning.
Good morning, how are you?
Morning.
I'm very interested on this procedure, so thank you very much for the opportunity to observe the surgical technique to use this kind of device. I was wondering what are the indications for, I mean, do you always treat patients with hyperactive bladders and the two-source sphincter dyssynergia with a stent procedure? Because in our protocol, we try to avoid incontinence as much as possible.
Yeah.
And using a stent is accepting incontinence, which kind of as a contradiction for the urologists. Is urologists have been trying to protect continence at all costs and in every other pathology. But in spinal cord, we accept incontinence in some patients. So what's your protocol there in Valencia? Because in our center in Chile, we try to protect continence at all costs. We even prefer a continent diversion over incontinence.
Thank you very much for the question. Our first step in dyssynergy patient is not the prosthesis, not the toxin, but the botulinum toxin, not the sphincterotomy. What we consider, if the patient is not handled well enough with antimuscarinic and with catheterization, or the patient is not able to use he doesn't have any caregiver to do the catheterization from themselves. If it has a very high risk bladder, we need to reduce the pressure of the bladder. We have the same opinion about incontinence, but we put the kidney function first. We want them to be dry at our first intention, but if the patient is not able to empty the bladder himself, or he doesn't have any help. What I said before, in the first 6 months of the trauma, it could be a chance of giving some time to be more independent of the caregiver. But in the long run, if the patient have the established neurological disease, we try him to be on the oral medication and catheterization. If that's not possible, and you have to do a procedure before any invasive technique like the ileal conduit surgery, we go for a stent.
I see. And what is your long-term follow-up of the stents? So, or you need to?
We have been doing this ALLIUM stent since 2012.
Yeah.
Okay, so we have like a patient who has already 3-4 change of the prosthesis, and it's not a published data, but we have around 13 patients with dyssynergia who go for this kind of treatment. At the beginning, it is not a real alien, just alien patient, because at the beginning we have used a different kind of prosthesis, so the results are not very homogeneous. But we have seen migration in the bladder, we have seen calcification, but I can say over 70% of patients have a reflex micturition in the condom catheter without any severe complication.
Oh, I see.
Dr. Reynaldo, for the people who don't know you, you are the president of SIU in Chile, right?
Oh, yes, sir. Yes, I'm actually the president-elect of SIU, so I'll be the future president of SIU.
Oh, it's big honor to have you today in our webinar.
Thank you. Thank you for the invitation.
Hope to visit you and perform some procedure with you soon in Chile.
Oh, really?
Yeah, but you know, now in those days, all the flights are canceled, so all over the world. So it's we will need to wait for a while until it starts.
That's too bad and sad. Very sad. We're all locked down at home and covering only emergencies at the hospital. We are seeing some promising, optimistic figures in our country. So we hope that, but like in the same other countries, that we will observe on reduction of the pandemic, so we can go back to our normal life. And that is a situation, I'll be very happy to have the opportunity to stay with you here in Chile.
Yeah, we hope also for better days, and we hope it will come soon. And again, we can go travel and holiday, and hope for better days. Keep safe.
Yes.
Yeah. Thank you for joining us today.
Thank you for the invitation.
Welcome. So if you have someone has another question, you can share your question with Dr. Bonillo or with Dr. Gomez. If not, we will go right through to the quiz. Just a second. Dr. Bonillo, can you give me the host?
Yeah, I'm trying.
In the meantime, I share in the chat box the link for the quiz, so you can get in after that and answer the questions. Yes, I got it. Thank you very much. Okay. Okay, so first question, what is diameter of OPS stents? You can answer on the chat box. Okay, so BUS it's 22, and TPS and RPS it's 24.
Mhm.
What is the recommended device to dilate the stenosis? Cold knife, ureterotomy. And how much should be the dilation? Doctor, you can explain the answers if you like.
Should I?
If you want.
Okay. No, the diameter of the urethra should be 45. The 45 is the stent, but the urethra must be dilated to 28 French. So you can manage the OPS without any difficulties. What I was saying at the beginning of the talk, ALLIUM stent is the one of have 3 years studies. Those questions are more for general urethral stenosis structure, but we have to take into account that the answer number 1, 2.4 centimeters is the minimum length between the sphincter and the bladder lid. As I said before, in general speaking, the stent can be protrude out slightly into the bladder till 0.5 centimeters. As I tried to say it in the speech, a patient has to avoid all of that: intensive physical activity, volatile blood pressure, cycling. Of course, all of the above are not recommended to do. Okay. As I said before, the TPS or the bus stent are 45 French diameter. And what make special this stent, the polymer coating, reduce the rate of calcification, crustation, and stone formation. Concerning about the bus stent, it doesn't have any marker, but the TPS has two.
Right.
Okay.
Yeah, thank you very much, Doctor. It was very interesting, as usual, as last week. Hope for many cases to come.
Yeah.
And just wanna say that I hope that we will have better days without the corona, and all of us will come back to normal life. And see you soon in Valencia.
Okay, you're welcome to come again.
Thank you. Thank you.
Thank you very much, everyone.
Thank you very much, Dr. Bujilo.
Thank you very much, Doctor.
Stay safe.
Great lecture. I appreciate that. Hope to see you soon. Keep safe.
Keep
Bye.
safe, Bernardo.
Bye. Ciao.
Gracias, Miguel. Hasta luego. Hablamos.
Gracias, Julio.
Bye, bye, Doron, and everybody.
Thank you, everybody. Hi, Tao.
Bye, bye. I continue my trip. Bye.
How are you, Tao? Tao, you need to unmute. Carlos, how are you, Carlos?
Hi, there.
No,
Finally,
how are you?
Fine, thank you.
We saw 250 participants from China.
Wow.
Wait, now we cannot hear you. You need to, okay, now.
Yeah. Have over 300 audience from China to watch the lectures.
250 people, doctors.
Yeah.
Very nice. Very nice.
Thank you.
How is the situation now in Beijing?
So next time, we
Cannot hear you. You need to, okay, now.
yeah, have over 300 audience from China.
Ciao, last time. Ciao, hi. How are you?
Good.
Thank you. Thank you for your help with Tirza regarding the funds that we are looking to raise for China. We are getting ahead in the process, and we will have an auditor coming next week. Hopefully, we will get that grant.
Okay.
Last time you told me that the number of popularity is like people that pressed like, or is it real participant that watched the webinar?
Yeah. But this time have around 300.
Yeah, but this number, the 317 popularity, is that people that watch the seminar or people that just click the link?
Actually, it's the click.
Click the link, and you don't know how much time they were on the link.
Yeah, it's true. Sure. Yeah.
Good.
Okay.
Hi, Carlos from Santiago.
Hi. Don't know if you can hear me or not.
Yeah, we hear you. We hear you.
Okay. Nice. Here we are. Not 200 people, but 2. This is a 19 million country just.
It was very, very nice to see Dr. Gomez.
Yes.
And,
for me, that's very important.
Yeah,
and I believe for ALLIUM.
Yeah, and what Dr. Bonillo said before, that they are now have 30 patients with this indication.
Yeah.
And soon they are gonna publish the data.
Yes. Yes, I understood that.
Yeah, so it's also very good that Rinaldo had the chance to talk with him.
Yes.
Maybe it will be like a door opener.
Yeah. Well, yesterday it was also Rodrigo Campos from the same center.
Yeah,
so I believe we have a chance there now.
Yeah, I saw that he connected yesterday, but because I'm not speaking Spanish,
yeah,
I didn't talk with him, but I saw that he was connected.
Yeah. Well, we are working. That's important. Soon we will have more stents, I believe.
I believe, yeah, I'm sure you're on the right way.
Thank you.
How is the situation in Chile? Getting better?
Getting better. Numbers are better. The situation is the same. We are locked down, and hospitals are all working just in COVID, just emergencies, very strong emergencies of other specialties are being attended, but hospitals are working almost in COVID, not other things.
Everyone still in lockdown?
Yeah, 50% of the country is locked down.
Wow. Also in Santiago?
Santiago is the biggest city in the country, 7 or 8 million people. So we are the 45% of the 50%.
Yeah, I saw it's very, very bad in Brazil.
Well, that's worst.
Yeah.
That's worst.
Yeah.
That's worst, and USA, it's not looking well.
So to say hello to Maurizio.
Okay.
And
thank you.
Stay safe and healthy.
For all you too.
I hope to see you in the summer.
Hope. Let's see.
Yes.
Okay, nice. Thank you very much.
Thank you. Ciao.
Ciao, ciao.
So thank you, everyone. We are just us, so we'll let you know about the next webinar on 23rd of July.
Okay.
I will send you the invitation. Thank you. Have a good weekend.